Welcome back, ladies and gentlemen. Thank you, ladies and gentlemen. We'll make your way to your seats. Thank you very much. This is one of those sessions that we planned for when we were planning the conference. And when we were finalising the program for the conference, it was pretty clear that we needed to set some time aside for the health budget. We weren't really certain what the session would cover, but so we left a blank in the program. But we expected that there'd be significant issues in the budget that we might like to discuss. Well, what a budget it was. The budget overview states that spending growth has been significantly reduced, and the net impact of policy decisions has been to reduce the deficit by $36 billion over the forward estimates. But it seemed to us there was no health policy in the budget, only fiscal policy. And I thought we might be hearing more of the vision for ongoing reform of health yesterday, and we didn't. In the lead up to the budget, the government spoke of price signals in the health system and that people who could afford to pay for their health care should. The health budget contains plenty of price signals and opportunities for people to pay for their own health. The $7 co-payment for GP consultations and out-of-hospital pathology and diagnostic imaging services, to name a few. Medicare rebates have been frozen for another 2 years. Only GP consultations will be indexed, which means that everybody will be increasing their out-of-pocket costs, every single person who attends a medical practitioner. A new Medicare safety net with lower thresholds, with limits that make the thresholds harder to reach and reduce benefits once you reach them. There are higher co-payments for the PBS. Eligibility thresholds for the PBS safety net will go up each year over the next 4 years for all patients. Income thresholds for the private health insurance rebates are frozen. Finally, there's a clear statement that this federal government doesn't think it has any role in public hospitals. So today we cover 3 big-ticket items. The first is the impact that price signals have in health. And we're very fortunate to have Professor Elizabeth Geelhode to speak on the topic. The second big-ticket item in the budget is the seismic changes to the public hospital funding arrangements, which reduce the Commonwealth funding going forward and reduce the growth by $1.8 billion over 4 years and $15 billion from 2024 up to 2024-25. Now, I'm going to make a presentation on public hospitals in the context of health reform that I've witnessed through my term as Vice President and President. And finally, Brian Morton will speak about the $7 co-payment, which reduces the health budget by $3.5 billion over 4 years and affects pathology and diagnostic imaging as well as general practice. Now, with that, I'll invite Professor Elizabeth Geelhode to the podium. Professor Geelhode is Professor in Health Economics at the University of Western Australia's School of Population Health. She's also Head of School. Liz has served as Senior Policy Officer with the Genomics Directorate of the WA Department of Health and as a Research Officer in Health Economics at the University Department of Medicine at Sir Charles Gardner Hospital. We've asked Liz to look at the theoretical underpinnings of a price signal and the potential impact within the Australian health system. We absolutely welcome Professor Elizabeth Geelhode.
Thanks very much for the opportunity to speak. I'm always keen to put the health economic perspective on issues, and as Steve said, I've been asked to speak on price signals and in general. It's not going forward. An IT glitch? Doesn't seem, yeah, green isn't taking, there we go. Okay, thanks. So I'm going to look at the economic reasoning for price signals. I'm going to look at the potential impact of these price signals in health. I am going to concentrate particularly on the co-payment for GPs, simply because each co-payment needs to be considered in the light of its own evidence and its own impact, particularly the distributional impacts, as I'll come to a bit later. So I think that the $7 co-payment is flawed, and that's the conclusion that I'll come to, and I'm basing that on grounds of both equity and efficiency. But other co-payments, there may be separate arguments for other co-payments. So I thought I'd just leave it up to you to decide whether I'm a sensible health economist or not at the end of this. So just at the starting point, and I know this is fairly well known by probably all of you, but it's just good to be reminded at the position that we're starting from in terms of what we need to do in our health reform. So we know that the demand is increasing faster than population growth. We know we have an ageing population. We know we're treating better and better, so a lot of what were terminal illnesses before are becoming chronic illnesses. We know that technology is increasing at an exponential rate. There are a lot of commercial undertakings in technology now that have to be dealt with in ways at the Commonwealth level that cost a lot more administration, similar to the way drugs come through the PBAC. And we have increasing expectations. So we all expect to live a long and healthy life with minimal disability. And added to that, we have a declining dependency ratio. So we're having less and less people in the tax-paying bracket to pay for the healthcare that's going to be needed for the ageing population. I just thought this graph was interesting to illustrate to you the way that the idea of putting more money into healthcare is probably not going to give us better returns. The typical example is in the United States, where they use twice as much proportion GDP, and their health indicators on almost every indicator is much poorer. There's really good comparisons between the United States and Japan, between the United States and even Cuba, who spend roughly the same or have roughly the same health outcomes for far, far less expenditure. This particular graph looks at total GDP per capita and life expectancy, but we get the same curve whether we're looking at health expenditure per capita and healthy years of life gained per capita. So we're getting a marginal return on the amount that we keep putting in. So one way or another we need to look at health reform. So back to just that starting point again, the other 2 points there are that universal healthcare is both desirable and necessary for optimal economic outcomes. This is maximising economic productivity, depends on a healthy population, a healthy workforce, and universal healthcare brings those lower groups up to the standard that we expect in our healthcare. So reform initiatives, I'm hoping we all agree that reform initiatives will be required. The situation is unsustainable in the direction that it's going, so we need to do something about it. Where do we go from here? From a health economics perspective, any reforms need to address both efficiency and equity. So in terms of the co-payments as a reform initiative, the idea that has been put forward is, and it does have some impact on reducing overuse of services. So the question of whether or not there's overuse of services is again subject to debate, but if there is, then a co-payment can impact on that. Increasing revenue, so there's more money going to the government to pay for healthcare generally. Raising awareness of the cost of services, and there is certainly an argument that especially the cost of a visit to the GP is not appropriately valued by people because they are subsidised, they don't see it, they don't value it the same as if they had to pay for it. And then just a quote from Peter Dutton was about using bulk billing appropriately, which I didn't think was a very good argument. But these are the points that have been put forward for the potential for the gains in the co-payment. So just to give the economic theory behind price signals is that it conveys information to consumers and producers to trigger an increase in supply or a decrease in demand. So that we've all experienced situations where there's been crop failures, so certain vegetables or fruits are in short supply, the price goes up. We make a more conscious decision about whether we buy them or how carefully we buy them. That's the price signal. That's had an impact on the demand. In the same way, if there's a shortage, suppliers will intend to increase supply so that because there's the increased demand to satisfy that supply. In a market economy, and the operative phrase there is in a market economy because it's based on what we call perfect competition. Anybody that's done any economics in Economics 100, you learn about the assumptions about a market economy, perfect competition, reaching the point of equilibrium between demand and supply, the invisible hand, all of that. All depends on these very important assumptions, which in a large part don't apply in health. So the first one's perfect information. Well, that means that if you're paying more for your bananas or your butter, you can appropriately value that commodity. The issue in health is that we go to see a doctor because we don't know how serious our condition is or whether we need that addressed or not. Maybe we do, maybe we don't, but we don't have perfect information. We call that information asymmetry. It's very prevalent in health. The prices set by supply and demand, that's automatically affected by government intervention to subsidise. So equity gets in the way of these assumptions of the market economy. Driven by consumer behaviour, in health there's a lot of uncertainties, there's a lot of risk-taking. It means that people don't respond in the logical way to these price signals because of those other factors. And the externalities, well, there are a lot of externalities. There's contagious diseases, so whether or not we have our vaccinations impacts on the community. We often have carers, and the carers, whether or not we get treated and we become more ill and more disabled, impacts on our families and our carers. So the assumptions underlying the market economy generally don't apply in health. That's not to say that we can't apply the tools, but we have to be careful how we do. And just as an example, this is a quote from a Professor of Economics in the University of Massachusetts, where he's saying America's health system does depend a lot more on competition and those very strong economic underlying principles, more so than, say, in Australia and a lot of other economies. However, health is commonly treated like a regular commodity, and it simply doesn't always work in health. There are some areas where it can be treated like a commodity, perhaps complementary medicines, some of the preventive areas, but there are a lot of areas where it just simply doesn't work. So what evidence is there to underlie the co-payment, particularly in GPs? Well, I'm sure everybody's heard of the commonly cited RAND experiment. It's come up time and time again. It showed little overall impact on total visits, and that's what we would expect. We talk about a low elasticity of demand in visits to the doctor. And what that means is that people go to the doctor regardless. They feel they have a need. If the price goes up, most people will simply go and realise that they have to pay the extra. So the average impact overall will not change all that much with the co-payment, but it's the distributional effects that are important here. So the issue is that there's a disproportionate effect on low socioeconomic groups and chronically ill, which was shown both by the RAND experiment, which is a little bit old now, it's 3 decades or so old, but there's also a systematic review published in 2013 of these co-payments, which is across a range of countries, and that particular paper also covers a range of co-payment options in different areas. And again, they found that the vulnerable populations reduced their access to GPs more than the average population. So again, the overall impact, not that much. The average difference is not that great, but it's the distributional issues that are important here. So these same disadvantaged groups, there is a wealth of evidence from Australia and internationally that supports the premise that individuals from low socioeconomic groups demonstrate lower rates of primary care and higher rates of hospital care. So they tend to underuse primary care and they overuse hospital care, usually as a result of underusing primary care. So they're not following their asthma care plans, they're not getting their vaccinations. And this is precisely the area where people will be impacted, and this is the evidence that is shown by the co-payment. It's those vulnerable groups, and what they will stop doing is they'll stop going back for their preventive medication and their blood pressure checks and the things that they don't value. These groups usually have a higher risk factor profile, and this is just an example of smoking, and you can see that all socioeconomic groups have decreased their smoking in this time period, but the lowest socioeconomic groups have decreased their smoking less proportionately, and they're still smoking way more overall. And this really goes to show that these groups are the ones already making poor choices about their health. And Hockey's comment about talking about how it relates to a packet of cigarettes or middies of beer was germane, in the sense that it's these people who, since they are making the wrong choices, they are in a position where they're most likely to value their GP consultations more poorly than others who perhaps don't have the same risk factor profile. So my conclusion really is that, based on efficiency grounds, a co-payment is likely to exacerbate the trend of low use of primary care and high hospital use for vulnerable groups. How this would play out in a total cost effectiveness, it's hard to say, because you would need to look at the long-term effects of the hospitalisation that would be incurred almost certainly. It's the preventable hospitalisations that are the most reducible. Keeps coming back to primary care time and time again. Those preventable hospitalisation rates can be reduced. And then there's also the equity consideration, which doesn't seem to be addressed with this particular co-payment, and that is that lower income earners will pay a greater proportion of their disposable income, and so that's increasing inequality. Having come to that conclusion, I do think it's still important to say that consumers do value more what they have to pay for, so there could still be some room for co-payments, but it needs to be subsequent to consultation and appropriate evidence. Thanks.
Thank you very much, and I think you do indeed qualify as a sensible health economist. And it does make me think that it would be very hard to win an argument in the Gilhold household, actually. But sorry, Gary, where are you? Yep. Look, I think that's laid out the realities from a health economics perspective, and I've said publicly a number of times, it always worries me when the AMA starts agreeing with health economists, but I think on these matters it's really very instructive. And I do remind the room that we yesterday passed a motion to implement a new constitution, and number one in that new constitution is that we're working very hard for our members. And the second object is that we're also very interested in improving the health system. And so I guess we are, in this policy session, looking at an enormous potential impact on the health system. So if we start talking about public hospitals, from my perspective, over the last few years, and since in the last 5 years, 2 years as Vice President and now 3 years as President, there's been an enormous change in our public hospital systems. You know, with the National Health Reform Funding Agreement that we saw early on has now effectively been torn up. That agreement contained 3 funding guarantees for state and territory public hospitals that the Commonwealth now will not honour. They said that no state or territory will be worse off as a result of introduction of activity-based funding and block funding for smaller hospitals. The 50% of the efficient growth from 2017-18 onwards they would fund. and $16.4 billion in additional funding over the 2014-15 to 2019-20 period will be delivered. On top of that, the $201 million in reward payments for meeting emergency and elective targets 2015-16 to 2016 won't be paid. And yes, we heard yesterday that the investment in public hospitals is going up, but there's certainly a reduction in that increase in investment. Now, this is the graph that we had originally created to track the Commonwealth's contribution against the guarantees in the National Health Reform Agreement. And based on the information in the budget documents, you can see that this budget, shown by the green bars, is providing less funding than projected in previous budgets and the mid-year adjustments. But as the Prime Minister has hastily forced us to explain during this week, the Commonwealth Public Hospital funding is still increasing year on year. The Treasurer has told the states and territories that the shortfall is a matter for them. All we're left with is the promise from the Commonwealth of sensible indexation arrangements for hospitals from 2017-18. Public hospitals need certainty of funding arrangements to plan for and deliver services to meet the demands being placed on them. The nation cannot afford for public hospitals to be used as pawns in a political battle over sovereignty and reform of the Federation. The battle over public hospitals funding appears to be never-ending. It beggars belief that during my 5 years as AMA Vice President and President, how the pendulum has swung on public hospital funding. And we're all aware of the information that the governments have that make them extremely nervous about health financing. The entire world is facing the same issues with healthcare systems. These graphs are probably familiar to you. They track 200 years of costs and mortality in Massachusetts General Hospital and portray the value of healthcare dollars spent. I feel like a health economist, actually. We can see relatively high mortality early on in the early years at relatively low cost at the beginning, leading to growth in costs far exceeding reductions in mortality. I don't know if you can see the dates on that graph, but it's since the 1970s health spend is accelerated, whereas the top graph the mortality hasn't dropped as rapidly as the spend has increased. So maybe it's not about just spending more money. Now, those graphs obviously could be replicated for hospitals all around the world, including in Australia. If we plot the two major health reforms in Australia on the second graph, we can see in 1953 cost starts to increase when PBS was introduced. And from 1974, there's a huge growth when Medibank was introduced and continued with Medicare in 1983. 3 intergenerational reports are full of doom and gloom and have made successive governments nervous. For health, the first 2 reports predicted that the ageing population will result in a substantial fiscal pressure from increased demand on government services and rising healthcare costs. Now, health spending as a percentage of GDP is not actually what gave health reform momentum in the public arena, well, at least in the public arena in 2007. What got the community calling for action on health was ambulance ramping, long waits for treatment in emergency departments, waiting in corridors to be admitted to hospital from emergency departments, and long waits for elective surgery. In February 2008, the Commonwealth's response was to set up the National Health and Hospital Reform Commission to develop a long-term health reform plan for a modern Australia. The Commission was tasked with providing the Commonwealth with a blueprint for tackling future challenges in Australia's health system, with the rapidly increasing burden of chronic disease, the ageing population, rising healthcare costs and inefficiencies exacerbated by cost shifting and the blame game. Now, this is a pretty complicated slide, but after a year of whirlwind consultation with stakeholders, the Commission produced a blueprint for reform that covered all of the healthcare system. It may be that Christine Bennett's report's gathering dust in the halls of Parliament House. Now, if you look at the red box, and hopefully you can see some of that, the vision, and if you look at the goals in that red box at the top, the reform goals, they still apply. They still apply today. And we do need to have a vision, and we do need to have a set of goals to deliver reform. And if we don't, decisions that we make are not going to be the best decisions. Now, of course, after that, what happened? The Prime Minister Rudd and Health Minister Roxon took to the road and to the hospital wards to sell their plan for health reform. Under that plan, the Commonwealth Government would fund, remember, 60% of public hospital services, with state governments picking up the remaining 40%. There was a recognition then that the revenue is at the federal level. 100% of primary health care, including hospital outpatients, 60% of teaching and training costs in public hospitals, and 60% of the capital expenditure. Now, that seemed pretty good to the AMA at the time. There was a reason for health reform to coalesce. 100% of primary health care meant that it was sensible to start talking to each other about the most efficient place to spend this money. Now, many of you will recall Prime Minister Rudd attending the AMA National Conference in May 2010 to announce extra funding to even facilitate clinician engagement in service planning and delivery. I wonder how many of our public hospital colleagues here today have seen a real difference in their engagement. The kicker in the Rudd plan was the federal government would claw back the GST, and that's what knocked it over. Little by little, the vision for health reform dwindled as it became clear state governments were not prepared to sign up under those conditions. Well, we all know what happened to the Prime Minister at that time, but for the health sector, we saw our one chance of getting real health reform starting to slip away. A year later, in 2011, the federal and state governments signed up to a healthcare agreement that looked really nothing like the 2010 plan or the Health and Hospital Reform Commission plan. All we got was health financing reform, with activity-based funding and Commonwealth funding of 45% of the cost, and a few more government agencies reporting on health sector reform. These documents report against the indicators that were created in a hurry to make it into the 2011 agreement, but at least we now have more information that is presented in a way that gives us a better understanding of how the sector is really performing. If we don't measure things, we're not going to be able to change them. That information gets recycled in our AMA Public Hospital Report Card, and our report card, as you'll recall, is the only publication that provides a picture of performance year on year for comparison rather than spot readings. 6 years ago, the common thinking was that the ageing population was the driver of health costs, and we've been reminded today that it isn't. It's an entirely different paradigm driving health costs, actually generated, if you like, by us, the medical profession, because we can treat disease. We are being able to treat more and more chronic conditions. The most recent intergenerational report in 2010 showed a shift in the reasons for the increase in healthcare costs. It's not just the ageing population, it's the demand for services and the volume of treatments that we're providing. Now, if we take a look at Queensland, this shows the healthcare costs in Queensland. You can see the volume of treatment, that's the top graph. You can see the volume of treatment is responsible for a much larger proportion of the costs than the ageing population, and the increase in population for that matter. The sustainability of the health system and its costs is something that we need, the medical profession must be more engaged in. The Grattan Institute presents national data making the same point about the volume of treatment. And it's not only an increasing volume per se, it's change above the GDP growth level. So clearly Australia, as its GDP grows, if it spends the same proportion on health, we're spending more on health. But the volume of service growth is well above GDP growth, and that's a really important point. We are going to need to spend more on a GDP basis to keep up unless we do something. Now, all governments are concerned about the projected expenditure on health, and all the graphs have the same trajectory. The Commonwealth Government has used a very blunt instrument to deal with that forecast in what appears to be really a brutal way for states and territories. As clinicians, we should be equally outraged by the cuts to education because of the impact on the social determinants of health. So there's impacts on health, both inside and outside health. So what do the premiers do? They met last Sunday week to take a stand. Their communiqué declared that the unilateral termination of the intergovernmental funding agreements signed in good faith is unacceptable. They quantified the immediate impact on public hospitals as 1,200 fewer hospital beds across Australia, and they want the white paper on reform of the Federation accelerated. Once again, instead of a concerted effort on health reform, we're about to embark on yet another debate on tax transfers, another tussle over the GST. It's up to us to put a stop to this pendulum swing. The AMA has much work to do with both levels of government over the coming years. We have much responsibility to manage costs in the health system as any government. If we don't, we and our colleagues will continue to work under uncertain funding arrangements with incremental cuts to the price of services in the vain hope that this will turn the tide of volume. Increasing the price doesn't make you healthier. 5 years in the politics of public hospital funding seems like a lifetime. At the Commonwealth level, we've gone from an attempt to implement the AMA plan for a single funder for public hospital services to an unconscionable abrogation of financial responsibility for the public hospital sector. We need to be clear about the reform destination to all governments. We need to get from fragmented acute care to integrated primary care. We need to get from siloed health service delivery environments to shared electronic health information to provide seamless care and to avoid duplication and waste. We need a health workforce that is trained and organised to meet the future needs of the community. The AMA has to set the direction for true health reform. We have to make the diagnosis and present the treatment plan. Thank you, ladies and gentlemen. I'd now like to introduce Dr. Brian Morton to talk about the impact on general practice.
Thanks, Steve. Good afternoon. Hockey got it wrong. Abbott got it wrong. I'm here to tell you of the impact on healthcare, and you can trust me, I'm a doctor. In 2012-13, GPs provided over 115 million non-referred patient consultations, and that excludes the enhanced primary care items. The government's view is that with no price signal on health, the Medicare system is misused both by patients and providers alike. While the price per GP service is low, the average growth in outlays for government on GP attendances in the last 10 years is 5% compared to 3.9% for specialist attendances and 4.1% for operations. These are the numbers that drive the government to look at cutting costs. The latest bulk billing rate sits at 82%. This is despite inadequate indexation and repeated cuts or freezes on GP items over the years. Well, how's that possible? Well, we'll touch more on that later. But I think that's the reality test that we ought to have as number one. It's 82% of bulk billing. Of fee-for-service is bulk billing. When the budget is implemented, all patients, whether they are full fee-paying patients or not, will have their patient rebate decreased by $5. For the most common attendance item claimed, and that's a level B, the rebate will decrease from an already inadequate $36.30 to $31.30. And that's the second reality check. The rebate has been decreased and it won't be increased again. The $7 co-payment has been structured to ensure some co-contribution from currently bulk billed patients and to put pressure on GPs to A, charge the co-payment and B, keep the out-of-pocket costs for fee-paying patients to a minimum. GPs who bill the $7 co-payment will get a $2 increase in payments received. This is meant to be the sweetener, but it takes no account of the increased costs to practices for this collection. Even more concerning is the potential impact a $7 co-payment could have on our most vulnerable patients trying to access care. This co-payment structure will make it difficult for GPs to do anything other than charge concession card holders and under 16s the $7 co-payment. To reach the 10 service, that is $70 co-contribution threshold, these patients will have to be charged the $7 co-payment for attendances and any associated pathology and diagnostic images for the services to count towards that 10 threshold. After 10 services, the status quo of current arrangements under the bulk billing will return. the patient rebate will revert to $36.30. Where the patient is not billed for any additional services, the appropriate low gap incentive will apply. And if that's a bit confusing, think of adding the ECG, say, that will be paid to you if you bulk bill it at the 85% rate. You'll still get the low gap incentive. Thus, the GP will receive $42.30 to $45.40 depending on the applicable incentive, that is, whether you're metropolitan or rural. And that's as they do now. And the patient will have no further out-of-pocket costs to pay for a GP attendance. The government has made it that, for those patients, it will be in their interest for GPs to charge the $7 co-payment. Of course, actually, what slide is it for? That's the trouble with technology. It's slower than my hands. Not. Of course, there are times where the patients just can't pay. GPs will still have the discretion in such cases to waive the co-payment. The kicker with this policy at present is that every time a GP does so, they will take a loss of $5 or 14% on non-concession or under 16-year-old patients. For concession card holders and patients under 16, the loss will be even higher, 29% to 34%, depending on the applicable low gap incentive. If this sting is not enough of a deterrent to waive the co-payment, in all but the most needy cases, remember the service won't count towards the 10 service threshold, so no low gap incentive will be payable, and the patient rebate will remain at $31.30. Habitual waiving of that co-payment will ensure the patient never reaches the threshold and will see the GP absorbing a loss of between 14 to 34% every service to that patient. GPs will need to seriously consider who their vulnerable patients are, which ones have circumstances or illnesses that have genuinely left them unable to afford essential care. If we decide to offer a discount or waive a fee, what parameters will we set? Will it be a one-off? When will it kick in? For example, after the third visit in a month? What about for all our other patients? What clinical management issues will you have when patients have a minimum $7 or more out-of-pocket cost? How will you manage them clinically if they decide to ration their healthcare services? So it's if they decide to ration. How will you respond? Take, for example, the patient on warfarin, who instead of coming in every month for their INR, is now only coming every second or third month to have it tested. Will you need to consider changing them to a tenfold more expensive medication to maintain appropriate anticoagulation? It's $12 odd for warfarin and $96 for the novel anticoagulants. How will the $7 co-payment change the way we utilise diagnostic testing? Will we continue to concentrate on the most likely diagnosis and simplest and cheapest test first? Or will we test for all parts of the differential diagnosis in the one hit with a more comprehensive and expensive test? I.e., will we go from a plain X-ray straight to a CT scan? Will the $7 co-payment encourage best practice or steer GPs away from it? What will then be the true impact on health expenditure? Will it be fewer GP attendances? Will it be less diagnostic testing? Will it be longer, more comprehensive and more expensive attendances? Or more attendances at emergency departments and hospital admissions due to delayed diagnosis? We've all heard the anecdotes of the MBS gaming, and as a PSR panel member, I've seen firsthand the lengths a small minority will go to maximise their MBS income, and that's at the expense of the health system in general. While it may be clever to find the loopholes, it will do nothing to decrease government concern with the expenditure on GP attendances. It will only lead to continued focus on this area when savings are required, as well as an increased compliance requirements. And I'll say it again, I believe it's fantasy to expect the $5 loss to rebate will be reinstated. What will the impact of the co-payment have on immunisation rates, especially in Aboriginal and Torres Strait Islander communities and lower socioeconomic areas? GPs who lose money every time they leave the practice to visit a residential aged care facility will be expected to collect $7 from each of their inpatients. Or will they absorb the costs if they waive the patient co-payment? How practical is this really? How will it impact on the number of GPs continuing to provide this service? What will the impact on health expenditure be if more frail elderly are transferred to hospitals instead? What about the impact on the patient? The risks of hospitalisation in this group are well documented. Infection, deconditioning, loss of function, just to name a few. And they are likely to find themselves receiving more extreme care than they would have otherwise desired. If patients become more discretionary with their GP visits, as the government in fact is banking on them doing, what will the implications for patient health be? I can tell you there will be increased patient suffering, enhanced morbidity, lengthier recovery times. It could also turn a preventable or treatable prognosis into a complex chronic or terminal one. What compromises to care will GPs have to make if they refuse to charge the $7 to all but the most vulnerable? Will they have to increase their throughput, spend less time building a trusted relationship with the patient, spend less time on preventive health, refer more for diagnostic testing because there isn't the time to make a diagnosis? Perhaps it'll be prescribed more because the quick fix gets the patient out the door and the next one in. These are not things that the AMA want to see happen. The budget may provide the catalyst for GPs to enhance their focus on the provision of quality care and to reduce their reliance on bulk billing for all but our most vulnerable patients. This is an opportunity for GPs chained to the 6-minute medicine treadmill to free themselves and to spend the time with patients, time that is needed for effective and quality preventative health care, diagnosis, management and general care, potentially reducing in the process the number of diagnostic testing required, the number of prescribed medications and service required in caring for that patient. This budget also could be a catalyst for making people take greater ownership of their health. Maybe this could be just the incentive needed to encourage lifestyle change. Because if individuals don't make those correct choices, the cost to them personally for their health care will be greater. GPs need to be aware of the potential consequences of outright rejection of the co-payment. Government alternatives for cost control could be far worse. Can you remember any time that the rebate has been increased? The rebate has been generally decreased over time and has not kept pace with inflation. That's the great risk we have if we just say no. Practices who currently bill 100% of patients will need to implement multiple payment options for their patients. These will not only add to business expense, but also the practice's administrative burden. Each payment system will have its own set of reports and reconciliations. Outstanding payments and bad debts will have to be managed. These practices will have to install or modify payment systems to enable patient billing, including running a cash flow and installing additional IT infrastructure. They will put in place additional security measures if collecting and banking cash. They'll need to provide additional staff and train those staff in new payment systems, patient billing, secure money handling. They'll have to incur FPOS terminal charges, if not already using them, and the FPOS transaction charges associated with it. They'll probably have to pay more insurance if holding cash on the premises. They'll have to put in place a communication strategy to advise patients of changes to billing arrangements. For example, letters, changes to website, SMS prior to appointments. And they'll have to encourage patients to provide their bank account details to Medicare if implementing electronic billing and and patient claiming. GPs will have to review their billing policies. Will they charge us $7? Will they waive payments, and in what circumstances? Will they shift to full patient billing for all or just some instead? If not already electronic, will they submit patient claims or not? Any changes will need to be communicated to patients well in advance. Measures and processes for checking a patient's threshold status will need to be put in place. The government is committed to having this in place by the 1st of July 2015. It's going to be quite a challenge. Many practices who submit claims don't do so in real time. They batch the claims and send them at perhaps the end of the day, or maybe it's every couple of days, or maybe it's at the end of the week. Identifying when a concession card holder or an under 16 has reached that 10 service threshold in real time is going to be problematic. Many GPs will have to counsel patients with regard to why their out-of-pocket costs have increased, the value of continuity of care, preventative health, and why the test you've referred them for or the medication you've prescribed is essential. For those practices that already patient bill, the implementation of the $7 copayment will be much less painful than for those that totally bulk bill. These practices will already have electronic billing and claiming infrastructure in place, but their variable costs around transactions, security and insurance will likely increase. They'll also need training to understand the arrangements to communicate this to their patients. Now more than ever, we have a real opportunity to recognise and value the important role of GPs, pathologists and radiologists, the important role that they play or we play in our health system. But we have to make sure that government policy takes adequate account of the viability of our practices to continue to provide that quality medical care, as well as providing those for whom the costs of healthcare are beyond their means. And I think there are three core messages: protect the vulnerable, value general practice and radiology and pathology, change community expectations that doctors have a responsibility to implement government social policy. Our real responsibility is the healthcare of our patients. I'd like to move a motion to National Conference as part of this policy session. You all have the motion in front of you. It's seconded by Bev Robotham. I think it's very important to have an AMA position that communicates the problems. It allows us as an organisation to be distinguished from the others, to be distinguished from the non-government parties, to have a negotiating position, a place where we can come with a coherent policy to government to negotiate on change. I commend this motion to you, and I'll call on Bev Robotham, my seconder, to speak.
Thank you, Brian, for an excellent exposition on the co-payments and for your recognition of the damage to pathology and radiology as well as general practice. I just want to make a couple of extra points about the impact on pathology. First of all, it's another name for another fee cut for pathology, and it will obstruct useful pathology testing. Firstly, the fee cut. The co-payment in pathology cannot be collected in the 40% of patients having tests who are never seen by a pathology practice. Who is going to collect a co-payment on our behalf when they're already struggling to collect their own co-payment for the service they've just performed? If the co-payment is not collected, there's a financial penalty. If it is collected, we know it will cost more than the $7. This is a fee cut, and it will be managed, as the massive collection centre rents have been, by stripping more staff out of laboratories and making do with old technology. That's a problem for pathologists now, and in time for all doctors who need efficient modern pathology services to look after their patients. Of equal concern is the fact that many patients won't want to pay a co-payment for pathology tests. They'll act as their own fund holders and will choose to spend their 10 co-payments with their doctor, not the pathologist, and they will not present for tests. And so we go back to the dark ages, to a time when patients with chronic diseases and their treatments were not monitored, complications were not averted, and early diagnoses were not made. The model outlined in the budget needs revision. I commend the motion to you.
Thank you very much. Now, delegates can speak to the motion. Just as a bit of housekeeping, we do have an urgency motion session this afternoon, which will actually be closed to the media, and so you can speak freely this afternoon. I'm not expecting you not to speak freely now, but that's going to be available this afternoon. There's a hashtag I need to remind you of earlier, crosshatch AMA National Conference 14. If there's no speakers against this motion, we may put it, and we may then open the floor to questions from the panel. I suspect that we may get a bit of both of that. But anyway, the first speaker, can you identify yourself and then try and keep your comments fairly succinct to try and give your colleagues a fair go. And I'll remind you, we're between now and lunch. I'm very sorry about that, because clearly there's a motion in the room. It should be the same. Can we put the motion up on the screen again, please? Can you tell me, is it different?
Yes, it's different.
I'll ask the mover of the motion to tell us which version's the one.
Okay. The handout you've been given, the one on the table, is the correct version.
Thank you. First speaker.
Thank you, Mr Chair. Gerald Segal, delegate from Victoria. I want to say at the outset, I'm not opposed to co-payments, but it is going to be a huge problem for about 15% of my patients. These are the sort of patients who might bring a couple of children to see me, and then at the end of the consultation, the mother will say, "Oh, that's okay, doctor, but which script is the most important for me to get?" And I mean, if they're having that trouble, can we imagine what's going to happen? So there is big problems, and Brian spoke very well about them. To this motion, parts 1, 2 and the last one, I believe, are excellent. 3, 4 and 5, I would argue, should probably go. The important bit is about providing adequate access for vulnerable patients. I think that's absolutely imperative. And the last one, provide a real-time means to confirm patient safety and eligibility, is also essential. I'm really not, don't think the other three add anything and probably are not worth having, but I wouldn't oppose the motion, but just point out that I don't think they're worth having.
But while we're changing speakers, I'll remind the speakers that this is advisory to Federal Council, but we are very interested in your comments.
Richard Kidd, I'm a GP from Queensland, and like many of my colleagues, I know, in fact, the majority of my patients do pay a private fee. I'm essentially a private billing doctor. So for a lot of them, what this really is a $5 cut in their rebate. But I do have patients, as do all my colleagues, who we choose to bulk bill because we know they just can't afford to pay, and they're not going to be able to afford to pay the $7. And these are the patients quite often who have got chronic diseases, who are on warfarin and need regular blood tests, and sometimes need some fairly regular radiology. And these are the patients who are vulnerable. These are the patients who will come less often. Their control of their warfarin and their other things will go out the window. They will be preventable hospital admissions, and the outcomes for our patients are going to be dire. So I fully support the motion.
Thank you.
Mark Kangaroo, I'm a radiologist from Perth. Fully support the motion, but some further information that there are cuts in radiology in terms of the actual fee reduction. For a chest x-ray, it's another $9.92. For a CT scan, it's $34.50. And for an MR scan of the brain, it's $66 roughly. And that's on patients who are currently bulk billed or patients who are not totally billed privately. If it's a private billing, the increase to the patient is even higher. So if you've sent somebody in with a, let's say, abdominal pain, got a chest x-ray, plain abdomen, to see if there's any calcification or something in a CT, they're already about $70 odd out of pocket just on that one hit, because it's per item, not per visit. So I fully support the motion.
Thank you, Mr. President. Bernard Pernroe, convener of the National Council of General Practice. I thank Brian and Bev and indeed the other speakers of outlining the magnitude of the problem that we're facing here. And it is essential that some motion be carried from this national conference as an advisory to the Federal Council to formalise the feelings that we're hearing in this room this morning. As you well know, Mr. President, in 2 weeks' time, the Federal Council of General Practice will be spending most of 2 days thrashing out in great detail the Association's policy on this very issue. One of the things I like about this motion is that it is not restrictive. It does not back us into any corners. It's almost, and I don't mean this as a criticism, a motherhood statement, but a motherhood statement that I believe is very important and that be recorded. For that reason, I fully endorse it.
Thank you.
Hi, David Mountain, emergency physician from Western Australia. I'm afraid in its current wording I don't support the motion. It does not say what I think the strong feeling is, that the co-payment is basically a government tax that's going to be raised by GPs for the government. And I think all the speakers have eloquently shown why this is a detrimental tax for patients' health outcomes, and nothing in there says that and strongly opposes the government applying this. And I think we have to still say that as our public position. Now, sure, if they insist on pushing it through and they get it through the Senate, then that's fine. I think these things are all good. But I think having that out there without actually stating that we strongly oppose the co-payment in the first place is not the right way to progress.
Thank you for your comments, and I'd remind everyone that positive and negative comments both inform the new Federal Council, so thank you for that.
Dr Lorraine Baker, mover of the urgency motion to be heard this afternoon. I have no problem with points 1, 2 and 4. I am concerned that we're embracing the term co-payment, but most particularly that we have not presented in this motion a model alternative to collecting a fee on behalf of government and continuing and supporting the universal access to bulk billing by every patient, not just the indigent and needy. And I see this co-payment debate as a golden opportunity for AMA to engage in the debate about withdrawing from universal access to bulk billing, and that has not been presented convincingly by anybody so far in this debate.
Thank you.
Good morning, Dr. Sean Rudd, Harvey Bay GP. We've got one of the highest, or should I say lowest, socioeconomic status group, especially the elderly in Australia. I'm from a mixed billing practice. I think that one of the first things we have to remember is that the rebate is set by the government, and the rebate is an insurance which is for the patient and has nothing really to do with us, other than we should advocate for our patients, of course. There is 82% bulk billing. I believe there will be a co-payment, and unfortunately that's the wording we may have to use. I also believe that lots of patients are prepared to pay to see the doctor, as they already do. However, I do believe, as the motion states, that there are vulnerable people, and there's no point in listing them all out. But the important thing is 82% of our patients are not vulnerable people. And this is a golden opportunity to help our members get away from that continual bulk billing, sending people through quick medicine, and it gets us back to quality. And I think that if we charge what we're worth, we will give a quality service, we will do better for our patients, but we must look after the vulnerable and we must be compassionate. Thank you.
Tony Bartone, I'm a GP, I'm AMA Victoria President, I'm also on the Executive of the Council of General Practice. I support this motion. We heard from the Minister yesterday about red tape and reducing bureaucratic imposts. We heard from the Minister about the so-called GP windfall. These comments just underline how ignorant the Minister is about the economics of running quality general practice in Australia. The government co-payment model does nothing to support chronic disease management. Their model does nothing to support immunisation. Their model only seeks to block access to our most vulnerable patients in the community, the group in the community that we are compassionate and have been doing so for a long period of time. The motion, I believe, seeks and implores the government to sit down with Federal AMA and to basically make changes which support and not hinder and not penalise general practice, which we all know is world-class and provides quality primary care for the majority, for all of Australians. Thank you.
Thanks, and we won't take any more speakers. I'm already stealing some of your lunchtime, but go ahead.
Leon Massage, AMA Victoria Delegate. I wish to speak against the motion. And without preempting what Lorraine Baker and I are going to talk about when we talk, I'm one of the two people who was putting forward the urgency motion later on, and I think this tends to take a little bit of the bang out of that, and I would certainly argue against many of the points here. Certainly not arguing against the concept of co-payment, but this is not a co-payment. I think this tends to do what many of the motions I see here at AMA tends to dilute it, tends to weaken it, and tends to break things down into many things that, in my opinion, are motherhood statements. And certainly I agree with some of the other speakers who spoke for and against it, recognising the right of doctors to establish a fair base on the cost of providing a service. Well, of course, that's a motherhood statement. It already exists, so why bother stating that? You're basically accepting the co-payment as a co-payment, and I think we need to be very firm about what this is: a tax on GPs and a tax on everybody who actually pays a payment to their doctor. And I think that in its current form, it's totally unacceptable, and I would vote against it and urge you to do the same.
And we'll take the last two speakers, and then we'll get Dr. Morton might want to respond.
I'd like to support the motion, but in a limited manner. I have some acquaintances who are on seven-figure salaries who don't value my services as a GP. They think we earn too much money and that we should bulk bill them. My proposal is that we just start a conversation with government strongly. My Aboriginal patients don't have bedside cabinets, so they don't have $7 to bring to the service. So my proposal is no co-payment for concession card holders and a $500 safety net for others, and that is actually 70 services per year. So I would like to suggest that I have some support for the motion, but I think we're only at the stage of conversation with government and nothing else.
Thank you.
Alan Rosenberg, ophthalmology. I agree with the last speaker, and I do support the motion. But I just thought there are obvious modifications that have to be made, and may I make some suggestions? I agree that true pensioners, with true pensioners, there should not be a co-payment. I think with aged care patients, there ought not to be a co-payment, because I think that will really make a difference to the sector if co-payments are brought in. I think childhood vaccinations should not have a co-payment. I don't have a problem with children otherwise, but I do think that perhaps the arrangements for the safety net should be 10 visits for a family of children rather than for each child, and I don't know how easy that would be to arrange. But in any case, I just thought I'd throw a few of those ideas in.
Thank you, and the Chair will indulge the last speaker. It looks like he's going to give us the benefit of some wisdom.
Hopefully. Jack Best, our function, and we should in fact put in what is a much better view. And I've heard, people around the table, and they've got much better views than government. And I don't think we should be sucked in. We should look to realising that this health system, it's the worst series of media releases that I've ever seen. And the government, it's going to be an appalling situation in 6 months' time. And the only way that the government's going to get out of it is to ask the AMA to set up a collaborative effort, an inquiry, to get it all right again. Thank you.
Thank you. Thank you very much. And a few words from Brian, and I'll put the motion.
We have to remember that this motion actually calls on Federal Council to act. Secondly, it allows further discussion so that we can pull together an AMA model. So I take all the points, and I take the outrage from Leon and Lorraine as to they think it should be stronger, but we don't want to be painted into a corner dealing only with specific issues. And the AMA is not a mouthpiece for Labor Party. Catherine King reminded us that they are calling it a GP tax. Now let's get real. The language has to relate to what they've done. The rebate has been reduced by $5 to every Australian. Secondly, it is a co-payment. What we really mean, of course, is that the co-payment is the difference between the rebate and the AMA fee, and that's around $40. That's the co-payment we mean, and we are prepared to discount that to our vulnerable patients. It might be to zero, but we shouldn't be penalised. I commend the motion to you. I think it gives us flexibility to ask Federal Council to act. It allows us to develop an appropriate model to take to government.
Thank you, Dr Morton, and I'd again remind the room that every single comment that you made today has been helpful and instructive for your new Federal Council and the new President. I'll put the motion by a show of hands. All those in favour? Thank you very much. Any against? Okay, that motion is carried by an overwhelming majority. Thank you very much, ladies and gentlemen. We'll probably touch on some of these issues again later on this afternoon. I'll call the session to a halt and we'll break for lunch. Thank you very much.